small percentage of patients who ended up needing treatment and under what instances did they need it. As you might imagine, arachnoid cysts are not that common, typically in the temporal lobe or in the cerebellum. Yours is in the cerebellum. Tend to be a little more to the left side for some reason that he couldn't explain. I think yours is, yours is a little, not a midline, but slightly off to the left. Yep, right there. You see that?
Midline?
Yeah, right.
That's interesting.
Midline, but just slightly off to the left. And then he said, all right, how many of these grow? It was about 1% grew. And then what is the percentage of them that needed surgery? And it was like 7 out of thousands. So it was like, we're talking in the 1% range.
And those are the ones that are growing that basically impinge on.
That's right. So I would your arachnoid cyst with the couple of images we have does not seem to have changed in size, as I wouldn't expect it to. Nor do I think it's causing the symptoms. And if we shunted just the cyst, I think it actually wouldn't do that much good. Because again, arachnoid cysts are thought to be rarely symptomatic. They just kind of they're these little like pockets that your brain kind of grows around them. But there are very rare instances. Twice in my career, I've treated people with cysts. One lady, her balance was getting worse, and her cyst was growing. And
Cerebellar?
hers was actually convexity right parietal, kind of a weird location. Almost made me wonder if it was like post-traumatic or something like that. But put a shunt in it, put a catheter in it, and it got better. Her balance got better. But those are rare. Every week in clinic, I'll see at least 1 or 2 people with arachnoid cysts. And most of the time, honestly, they're found incidentally. Like people who had a car accident or bumped their head or whatever, and you find a cyst. And then you have to talk about what to do about it, and I always tell them, like, please, for the love of God, do not do anything. Leave it alone.
Well, it's pretty pervasive, too. I mean, just the nature of an arachnoid, it's not like you're going to lift it out of there.
No. You can't, like, strip it from the brain. So you have 2 options. One is to fenestrate it, like basically poke holes in it, and the other is to shunt it. Because you're right, it's not a mass that you can move away. It's really just a hole.
Do more damage.
You do. That's exactly right. So that's a great question. So what does the shunt mean? Catheter goes in the frontal horn. You're on the non-dominant side for most people is the right side. So just behind the hairline, shave a small strip of hair. Make a hole in the bone about the width of my pinky finger. The catheter goes into the ventricle through that hole and then tunnels to a valve that sits under the skin. I put the valve behind the hairline as well so that it's not too visible. But as I mentioned before in clinic, I try not to shave down the bone so that the valve sits flush. I don't do that anymore because it actually would make it hard to find. And I've had instances where it was actually hard to find because of that piece. So it's a little raised, and I like it to be a little raised. So
curious, why would you need to find it?
Yeah, so if you ever have an altered consciousness or a stroke or whatever, if you go to the ER, they need to know you have it.
Okay.
Not just because of the MRIs, right? If you get an MRI, it needs to be reset.
Yeah, exactly.
But also because there could be instances where you have a neurologic change and you get emergency medical care, and people need to know, like, no, this is a device in here draining CSF that's part of the picture.
Right.
Do you see what I mean?
I understand.
Especially if you're like out somewhere and then they don't have your record. Right. Do you know what I mean?
Yep.
So, okay, so then the valve connects to a distal tubing, a distal catheter. Now, in a baby, you can make a solid line from the head to the belly because they have little bodies and big heads. Adults is the opposite. So you have to have an intervene. You have to go here to here and then here to here. So the incision also behind your ear. Okay? And then you tunnel it under the skin of the neck, over the chest, over the clavicle, over the chest.
On top of the clavicle?
Yeah, on top, right under the clavicle's the lung. So it goes over, and if you turn.
So I'll be able to palpate it?
You can. If you like turn your head really hard, people won't see it, but if you turn your head really hard, you'll be able to like feel the indent of it. And the tubing is, if you look at.
Is it a plastic? It's plastic, right?
Plastic. It's about a third or a fourth of the width of this.
Got it. So it's pretty incidental.
Very small. And then that goes. Then I meet the general surgeons at the belly, and they put 2 little port incisions and cephalate your belly to see your abdominal contents, and then from there, we dunk the catheter we put the catheter into the peritoneal space under direct visualization. The reason I like the general surgeons, as I mentioned, we used to do open belly incisions. They're not big, but something like this, it's just like those muscles hurt to heal up.
They do.
So when you
I
have
can tell you from
right?
my splenectomy,
Yeah, it's a big deal.
It was not trivial.
So when they do the little ports and dilate, there's the skin incisions. It's a stab. It's like literally a puncture.
So they do it laparoscopically.
It's all laparoscopic. That's the point.
God.
That's the point.
Okay.
Okay. What else?
Nothing. That was the main thing. I just
assist.
Honestly, it was the first time Susie and I had seen that, the CT, the imaging.
Oh yeah.
So that it hadn't remarkably changed since 2018.
Yes.
We didn't even know at 2018 that it was there. Maybe we weren't paying attention.
It's so sometimes they're not even they don't even comment on them sometimes. And the radiology, I suspect it was probably in the read. I should have explicitly mentioned it. But so I could confirm that it's not something I think is related to what's going on.
Okay.
Yeah. I would not recommend intervention for your arachnoid cyst in the cerebellum. I don't think that's contributing, but excellent question. What else?
That's it.
Where's wife? Did she drop you off today?
Nope.
Okay.
She's, with the rain and everything else up in Santa Rosa, we get alternate transportation.
Yeah.
But she's gonna,
She'll come visit.
she will. She was very reluctant too. She says, I should be there.
Oh,
I should be there.
Yeah, it's hard.
Good morning.
Hi.
I'm going to take your vital signs and inventory your belongings, okay?
Okay.
Is it okay for me to use either arm for blood pressure?
Yes.
What else can we answer for you? Anything else?
No, that's it. I just, I appreciate you,
Of course. Thanks for the question.
That's, and this is the other thing, like that. I'm trying to grasp a word,
Yep.
and I'm just kind of hazy.
If we got
Mental
this
clarity.
right, your clarity should get better. But remember, it doesn't take days. It takes weeks to months.
Understood.
Especially since I don't like to just make the shunt drain a lot immediately. I start with a setting of 6, really to drain on the lesser side. 7 is in 0, or 8 is 0 drainage. 7 is the least amount of drainage, so 6 is like one step above that. You can get it down to a setting of 1, which is draining the most. I don't want to start there. That can
Because
make
you
it.
can, headaches and things
Yeah,
like
you
that.
just get over drainage headaches. You just people don't feel good, and you have a higher risk of getting a subdural with hematoma.
Because
As we
the
talked
brain
about.
is basically.
You're basically like flat,
Yeah.
like quickly. You don't want to do that. That's not good. We can gradually get there, but no, I wouldn't start there. Okay.
Thank you.
Okay.
Appreciate it.
I'm gonna find Dr. Carter. He didn't come by yet. You have not met a general surgeon yet.
Oh.
All right, my friend. Your IV's going to have to go on this side. So
The other side?
On this side, yeah.
Okay.
The same side as the surgical side. So I'm going to